do patients sit on the conversation with data, not just as it relates to HIPAA necessarily, but one, some places will be monetizing on data. There's two types, right? There's de-identified, and then there's not de-identified, meaning like you can identify, and that's usually an internal thing. With your policy experience, how much involvement should there be on a non-medical aspect of what people are doing with their objective things? As an AI enthusiast, I share all mine for everything. I'm like, yeah, if my REM cycles help your analysis on when people are in trouble, depending on the stage of REM physiologically, do it, But especially when it comes to revenue, I wonder if, is it just another means for profit for the healthcare system, not as the primary purpose?
It's complicated. I will say, patients' data is patients' data, right? And so certainly they should have access to it and to share it as they can. But an individual patient's data seldom is worth a lot on their own, right? And I don't just mean financially. I mean like the value of understanding that. Really, what we want to do is aggregate patient information for greater learning. So we can do things like augment what we've learned from clinical trials with real-world evidence. I mean, I think a great example of that is like when palbociclib was approved in the treatment of metastatic breast cancer. It was approved for women with metastatic breast cancer. Nobody was going to be able to accrue to a trial of men with metastatic breast cancer. Does this mean that men never get palbociclib? And so the Flatiron Group took information from their database to look at real-world evidence of men with metastatic breast cancer that were treated with palbociclib that then later ultimately led to an FDA approval. So if we are able to aggregate data, then it can be more meaningful to patients, to the healthcare ecosystem. There's some financial reward for that too, though I would say pretty limited, but there's some financial reward. So it's the data aggregation that becomes so powerful and meaningful, but that is complicated because it requires a lot of organizational investment in data architecture, in doing things like mapping and making sure that you clean the data, because most of that kind of real-world data is augmented with data from, say, the electronic health record. Well, the electronic health record is predominantly a billing system, right? And so when data is entered into the electronic health record, even in structured data elements, that may not translate into the true north. It's always going to introduce some biases. And I'll give you an example. So on Monday of this week, I met my patient with a stage 3 breast cancer, and I staged her breast cancer that, clinically, she has a T3N1 breast cancer by my clinical exam and by the availability of imaging that I had. And so I put that all on my health record when I saw her, as I wrote for her Keynote 522 chemotherapy. But then I ordered an imaging for her to understand if she had any evidence of metastatic disease, because that would be the standard of care. So what if next Monday when she comes back and sees me, I see that she has disease in her lungs or liver, and then she has a stage 4 breast cancer? Well, if someone had aggregated that data based on the best information I had at that moment, it's no longer accurate, right? Because she actually has a stage 4 breast cancer. And so the clinical record is imperfect because it changes over time. I mean, clinical stage changes to pathologic stage. We get informed by other information in the treatment journey that causes that to change. And we don't always change that in real time in the health record for a lot of reasons, right? And so we need to evolve for the health record to be easier for doctors to use. Never met a doctor that loves their health record because, who does? But so we need to change. And I think that this is a key point, Sanjay, as we think about AI systems and digital tools more broadly. We cannot expect that it's an unrealistic expectation to think that they are going to meet us where we are and support us perfectly. I think that, like all relationships, it's going to be a collaboration. And the AI systems and digital healthcare is going to improve where we are, but we have to change too in order to optimize what that collaboration is going to look like. And so what that means is we need to think about documentation differently. We need to update it differently. It needs to no longer just be a billing system, but we need to have the expectation that it's going to do things differently. We're going through a change right now in my practice in our communication architecture. And it's sort of a centralized system on how the phones are answered, with the goal of getting patients into the office faster and have their questions answered more quickly. And that's really important. And that's really important work. So I'm so happy about it. But we need to change too, right? Like, so doctors need to be available in different ways in order to manage the other side of that. And those are the growing pains that we're really seeing as we shift systems to a more modern communication architecture, is that we clinicians and our staff need to change as well. And we're not really accustomed to that. I have a managerial role in my practice over some of our regions. And what I'll tell you, if you don't already know, among most professionals, doctors and lawyers for sure, is nobody really feels like they have a boss, right? They really feel like they're their own boss. And in many ways, that's true. But it's hard to get people to change appropriately to adopt these systems. And this is really going to be important as organizations try to implement AI and digital healthcare tools. And as they sort of populate this journey to nirvana, is that they need to know how to guide and direct their people to change, to meet these technologies where they are, to optimize their results. And the natural consequence of not doing that is they're going to lose a lot of money and make a lot of people unhappy.
Yeah. I mean, it goes back to that, that axiom of just, if you look at what the lift is in a day or a week and, how annoying something is to have to like fix, learn, or change, it's not worth it. But if you look at the 3 month and the 3 year difference, to just, get used to it and familiarize yourself pays dividends later, much like flip phones to iPhones. I mean, there was a time where you just resisted because it was a headache. It was intimidating to understand how a touchscreen works. But obviously it's paid off. And when you're in an overextended, healthcare system, where I think the recent poll showed 48% of doctors, doctors across the board, all specialties, report burnout, like during their year's process. Even that little lift, which seems, small, can be major for someone that's already burned out. This has been an excellent conversation. I'd say one more thing, and this kind of blew my mind, because when we're talking about data and sharing, I've always kind of given this impression, and this is my personal, it's like when you share your data, especially de-identified, you're helping, hopefully, like humankind, because it's the observations of what's happening, at least as it relates to cancer, what happened, what didn't happen, what were the variables. It's with that we can kind of, collectively better understand the emperor of all maladies, to use Sid's title. He was on the podcast very early on. But then I was like, don't worry about it. If it's de-identified, what's it matter? Then I learned that there are degrees of de-identification. Like there's good, polished, clean, trustable. And then there's like, you don't know that it was de-identified, even if it was said to be de-identified. Same thing with somebody coming and saying, we clean your data, we organize your data, we structure it. Now you're going to have different degrees of like going to an auto shop or getting a plumber that's like way cheaper, and you think it's just cheaper, but then you find out, or the HVAC system, they use electric tape and all this stuff. It's just, like anything in life, you learn that there are degrees of it. Is there anything current or coming that can then actually measure in a qualitative way, or how well it organizes or cleans, or how well or solid or sound the de-identification process is? Or is it just kind of a trial by fire, learn retrospectively kind of thing?
I think there are ways to look at it. One of the ways that we use in health services research is to try to look at inter-rater variability, to try to understand, if you have one person who's sort of cleaning the data, if they're cleaning the data, in the same way, to try to understand if you're providing consistency. And consistency, we're all looking for the true north, right? So consistency, it means consistent. It doesn't always mean the true north, but I think that's one. There are many important ways that I think have been established to try to make sure that you have reproducible and better real world evidence. But that's been an evolution. Again, sort of people need to change. But if I can go back for just a minute to the idea of us changing and the benefits that you can have, I mentioned that my organization is struggling with this communication architecture shift right now, which is really important. But there's a promise. There's a light at the end of the tunnel there on this journey to nirvana. So for years, we've had a bunch of nurses that work remotely to help with triage. for the purpose of having faster response times to patients who are calling in with symptoms for symptom management. And for the last 4 years, we've implemented electronic patient-reported outcomes in patients that are on active cancer therapy. And by doing that, our average response time to patients that are calling in or digitally letting us know that they have symptoms is 40 minutes. And we've been able to study and evaluate and publish that we were able to do things like reduce ER visits, reduce hospitalizations, reduce the total cost of care when we implemented the system. And so that sounds awesome, right? It's better care delivery, and it is. I'm really proud of that work. I think that, it's the work of many, but I think that that's really important in care delivery. But now that we're shifting to this universal communication architecture across my statewide practice, we have the ability to grow those nurses to answering first call from 5 to 7 p.m. And you know what that does, Sanjay? It allows my doctors to go home for dinner and to see their kids play soccer and to go to their plays or whatever. It allows, this centralization of communication architecture sets the stage, and it's been a little painful. We have to change, but it sets the stage for a more efficient and effective healthcare ecosystem that gets patients what they need faster, that allows symptoms to be controlled and reduce ER visits, hospitalizations, total cost of care, and ends up being better for healthcare professionals because it decreases the burden of call in terms of the many sacrifices that we make in our own lives.